So we covered the distal part of the tib fib. So we're already familiar with this part of the extremity. You've got the lateral malleolus, the medial malleolus. Now there's an area over here. I don't think I did cover it on the last week. But there is going to be a smooth surface or an indentation of the tibial bone in which the distal fibula articulates with. So there is going to be a notch on the tibia. And so this area here is going to be known as the distal tibio-patellar joint. Tibio-fibular joint. The distal tibio-fibular joint. And then we make our way up. It also has a proximal tibio-fibular joint. So you have a proximal and then you also have a distal. So you have grooves or notches in the tibia to accommodate the areas of the fibula. All right. The length of the fibula is the body, right? The length of the tibia is also a body. What's interesting here is you have a very sharp edge that's anterior to the tibia, and that's known as the crest. What do we know the crest by?
Shin bone.
It's your shin bone, okay? So that's your anterior crest. Again, making our movement up, you have the tibial tuberosity. It is a bony projection, very, very rough surface. And you have a ligament attached to that communicates with the patella. Okay, so that's your tibial tuberosity. Staying with the tibia, you got two bony projections again that extend laterally and medially. Those are your condyles. Now, those also will have very rough surfaces for more ligament attachments. When we discuss the knee, I'll show you those attachments. Now, if you guys recall, condyles are directly related to a joint. Remember we talked about condyles and epicondyles? Okay, condyles are directly related to a joint. They are related to the joint. Epicondyles are not. All right. The very top of the tibia, you have a smooth surface up there. This is known as your tibial plateau. I don't know if I have a better image of that. Okay, tibial plateau on the very top of the tibia. And the plateau is their smooth surfaces. So on each side, on top of the condyles, okay, and the top surface, they're smooth. Okay, there's also a groove there. And what do you think is going to sit on top of those grooves?
The femur?
The femur. Okay, so the femur is going to sit right on top of the condyles. The plateau, again, especially, is a smooth surface. All right. I think I covered everything on this page. Oh, on the very top. On the very top. So on either side of the tibia, you have smooth surfaces, but on the very middle, you have the intercondyloid eminences, also known as tubercles. Very, again, rough surface. Anytime you have a rough surface, there's going to be some sort of attachment there, right? That's going to be the attachment for your ACL and your PCL. Have you ever heard those terms before? Mm-hmm. Okay, your anterior cruciate ligament and your posterior cruciate ligaments are going to attach to those surfaces. And that's the eminence. All right. Here we have a lateral image of the tib fib. The apex of the fibula is at the very top. It also has a head and a neck. We already talked about the body. What I want to focus on here is the tibial plateau. Okay, the very top of the tibia, the smooth surface. It has an angulation from a true 90 degree of approximately 10 to 20 degrees posteriorly. Okay, so when you keep that in mind, okay, there's this angulation right here. This is going to be your joint space between your tibia and your femur. Okay, remember the femur is going to sit right on top of that. because there's an angulation of between 10 to 20 degrees, what do you think we need to do with our x-ray tube to open up that joint space?
Angle it.
Okay, 10 to 20 degrees which way? Towards the feet. Okay, so caudally. Okay, so 10 to 20 degrees caudally. So keep that in mind when we talk about positioning. All right? And then you can also see here that the fibular malleolus is more posterior and also inferior to the tibia. All right, so distal femur and the patella. Here is the bottom. Here is the bottom, or the inferior view of your femur. You have a medial epicondyle and a medial condyle. Lateral, you have a lateral epicondyle and lateral condyle. These condyles, the condyles of the femur is what's going to articulate with the condyles of which bone? The tibia. Okay, so the femoral surface is going to articulate with the tibial surface. The bottom of the femur has epicondyles, more projections that extend from the condyles, and those are not involved in the joint. It's only the condyles that are involved in the joint. All right. Talk about the movement of the patella. When your knee bends, naturally what's going to happen is the patella is going to be drawn downward. Not only is it going to be drawn downward, but it's going to pull it closer also to the femur, okay, closing up the joint. So when you bend your leg, patella is going to move downward and also move closer towards the femur. When we're taking x-rays of the knee, there is a limitation to how much the leg should bend. We want to keep it open because also when you have the knee fully extended, the joint space between the patella and the femur can also close up. So we got to bend the knee slightly to open up the joint between the two bones. And if you do it too much, it's going to draw it closer to the femur and now you can't see the joint space either. Okay, so there's generally about a 20-degree bend on the knee for proper lateral knee that we'll talk about later on. The back side of the femur is known as the popliteal surface. The front side of the distal femur has a patellar surface that articulates with the patellar bone. The patella is going to be, we already talked about sesamoid bones, right? Okay, usually associated with the joint. It aids with the movement and articulation, and the largest sesamoid bone that is found in our body is the patella. Okay. The joint space between the patella and the femur, that joint is called the patellofemoral joint. The patellofemoral joint. And the patellar surface has a groove. Okay, it's either called the intercondylar sulcus or the trochlear groove. All the names are analogous. They're the same. So the patellar surface, intercondylar sulcus, and the trochlear groove, they all mean the same thing. So this is the anterior surface, this is the posterior surface. Notice there's a groove here, a very huge indentation, or a fossa. This is known as the intercondylar fossa, or the notch. Now that opening is a tunnel that allows passage for your ACL and your PCL. It allows passage for your ACL and your PCL. Any questions so far? No questions, okay. Let's talk about the anatomy of the patella. This is where it gets a little bit confusing because the apex is usually on the top and the base is on the bottom, right? In this case, and it looks like a guitar pick, the very top is the base. And where it points is the apex. So the base is going to be towards the head, the apex is going to be towards the bottom. You have two surfaces. You have an anterior surface and you have a posterior surface. The posterior surface is going to be smooth. It needs to be smooth because with your leg extending and bending, there shouldn't be any friction between the patella and the femur. Now the front is going to be rough. Okay, anytime you have a rough surface, what are we thinking about there?
Attachment.
There's going to be some sort of attachment, okay? So this is where one of the ligaments is going to attach. It's going to attach to the patella, and then remember that tibial tuberosity? The other end is going to attach to the tibia. All right, any questions so far? That's all we need to know about the patella. Base, apex. Anterior surface rough, posterior surface smooth. So here we have the knee joint. How we're looking at this is we're looking at it through the back side. The femoral tibial and the patellofemoral joints is what forms the knee joint. So the joint is formed by the femur and the tibia, and the patella and the femur. The fibula is not part of the knee joint. You guys need to write that there somewhere, okay? The fibula is not part of the knee joint because it's not involved in any of the articulation. Now remember the intercondyloid fossa we were talking about of the femur? That tunnel? This is where the ACL and the PCL are going to pass through, your anterior cruciate ligament and your posterior cruciate ligament. Now there are other ligaments. We talked about 204. The other one are going to be your collateral ligaments. You have your fibular collateral, and then you have your tibial collateral, or your lateral collateral, or medial collateral. So the whole purpose of the ligaments is, one, your cruciates control flexing and extension. Okay? And it prevents any type of hyperflexion or hyperextension. Same thing with the collaterals. The collaterals are located on the side of the knee joint, so it prevents any type of side movement, keeping the knee stable. Okay? So the cruciate prevents anterior and posterior movement. Collateral prevents any type of abduction or adduction of the joint. All those four ligaments controls and stabilizes your knee joint. Here's a closer look of the knee joint. We talked about the ligaments, but what I want to mention here now is the meniscus. The meniscus are disc-shaped structures that are located between the tibia and the fibula, and they act as shock absorbers. Very similar to that of the disc found in your vertebrae, so it acts as shock absorbers. Now, is it possible to rupture those discs? Okay. Yes, the meniscus, you ever hear that? I have a torn meniscus, or I injured my meniscus. Meniscus injury generally happens with those individuals who are involved in some type of sports where there's a lot of stopping, okay, and sideways movement. So you have football players, gymnasts, of those type tennis players are generally the ones who injure their meniscus. Okay, sudden stops and puts a lot of tension and pressure on the disc. But we also hear about those who tear their ACL. ACL is generally the a career-ending injury to athletes. Okay, because when you tear any of those ligaments, your knee is no longer stable, and you're kind of a liability to the team. When I was 15, I was horsing around, and I'm not going to say exactly what I was doing, but I was horsing around, and my knee or my leg hyperextended, so it bent the other way. So basically, my leg hit me in the face because it bent the other way and went boom and hit me in the face, and then popped back into the joint. I was rolling and thriving in a lot of pain, and I was grabbing my leg, and I couldn't feel my patella. My patella was all the way on the back side. Yeah. So I essentially tore up my ACL, but I'm not an athlete, so it doesn't matter. But I tore it up, and I had to go into emergency surgery that day. So I remember going into urgent care, getting checked, talking with the nurses, and next thing I know, I woke up in the same room. I don't even remember going to surgery, and I was happy. Happy drugs. But yeah, it took me a long time to heal from that injury. Almost a year. But it was perfect because I had the best gig. So I was still in high school, and so I had to walk around in crutches. So who do you think was carrying my books around?
Girls.
That's right. And I faked it out for a while after that. Even after I was okay, I was still faking it out a little bit. All right. So the joint, okay, I wrote down here the joint, it is a synovial joint, meaning that it has a synovial sac that allows for lubrication and free movement of that joint. Okay? So it is a synovial membrane which lubricates the joint. And the distal femur and the proximal tibia is going to be covered with a slick hyaline cartilage to ease in the movement or prevent any type of friction in any of the movement. Okay? Do we have any questions on this page? Okay, and then the articular capsule, we're talking about the bursa. The capsule contains the synovial fluid, again, that assists in movement of the knee joint. When we are doing an arthrogram, arthrograms are generally performed with synovial joint spaces. So we're talking about the shoulder, the hip, the knee. Did we talk about that, taking synovial fluid out and injecting it with contrast? Okay, so this is an example of an arthrogram. What you're seeing here is the contrast filling up the bursa of the knee. And once we fill that up with contrast, we take x-rays in different positions, whether it's done by the radiologist or by yourself. We are evaluating that space. Also, what can happen is, in addition to taking normal x-rays, we'll keep the contrast in there, and then we'll send them to the CT department for additional views.
So the contrast is like the outline portion?
Yeah, so what we're looking at here is, this is contrast right here, and then right behind that are the fat pads. Remember, fat is a little bit more gray or dark, so you're not going to see that radiographically, but the contrast is outlining that area. All right, more views. We're going to we'll be talking more about the intercondylar fossa here in just a moment. All right, so anatomy and review. You guys like doing this stuff? Okay, what's A on your left?
That's the medial epicondyle, or
Okay, remember the tibia doesn't have epicondyles.
condyle.
Okay, so it's condyle. Okay, so I have the medial condyle for A. B,
Is it crest or the shaft?
crest, shaft. Okay, body. C,
Medial
medial
malleolus,
malleolus. D,
lateral malleolus,
lateral malleolus. E,
shaft of fibula,
shaft.
Neck.
neck,
Head.
head.
Proximal tibiofibular joint.
Is it pointing to the bone?
No,
It's the apex,
Oh, the apex,
of the
oh.
fibula. Okay, so what is the joint called between the fibula and tibia here?
It's the proximal tibiofibular.
Proximal, tibiofibular,
Fibular
and then
joint.
here we have the
Distal.
distal tibiofibular. Okay. HII,
Lateral condyle.
lateral condyle. Okay, not epicondyle, lateral condyle, and then on the very top, J.
Intercondylar eminence.
Okay, your eminences. Your eminences, okay. Now, A on the lateral. It's the same thing as J on this, right? So
It's eminence.
it's your eminence. B is that bony projection, rough surface.
Tuberosity. Tibial
Okay,
tuberosity.
Tibial tuberosity. C,
Shaft.
C in the art, your body
Shafts.
shows your shaft. And then F, which is lower. Lateral or fibular malleolus, and then E.
Is that the joint? Or is it-
It's referring to the other malleolus, I
Oh.
think. It's the tibial. Okay. All right. Start here on the. So what we have here is we have two different projections of the knee. Here is an AP, a true AP of the knee, with an angulation to open up the joint space. If we did it perpendicularly, this joint space will be closed, but we'll talk about the nuances here in just a moment. So this is an AP knee, A,
Eminence.
eminence, B. Okay.
Medial
We know what C is, right? What's C?
condyle.
C is the femoral condyle, so then right above that should be,
Epicondyle.
okay, the femoral epicondyle. B, C, D.
Medial condyle.
Okay, that's the, okay. Is it medial or lateral?
That's
It's
lateral,
lateral.
because of fibula.
Because the fibula. See, you guys are good. You know what's funny too is I've been listening to you guys talk in class now, and 2 months ago, because I'm hearing superimposition. Okay, lateral, medial. When you guys are talking using medical terminology now instead of plain English, which is amazing to me. Because if you tape recorded yourself and you heard the way you guys were talking, you guys are talking like technologists now.
Yes.
Yes. But you guys remember a few months ago, you guys were confusing AP, PA, lateral.
Like what? What you talking about? You're talking gibberish, bro.
Those are basic terms that you guys were like,
In front.
I don't get this. And now you guys get it, right? Dorsal, plantar, anterior, posterior, medial.
Well, they get that
proximal.
one now after the test.
Yeah, right?
Superimposition. You guys are using medical language. I love it. Okay. So we said this was what?
Lateral.
Lateral.
Epicondyle.
Okay.
Condyle.
Not epi.
Sorry, condyle.
Okay. Lateral condyle. So condyles for the tibia. The femur has condyles and
And
epicondyles. Okay, but the tibia does not. Okay, so C, D, E. Smooth surfaces. Okay, tibial plateau. So this is going to be your tibial plateau. F.
Medial condyle.
Medial condyle. G. Medial condyle of the
Femur.
femur. Okay, E, F, G, H. Right above it.
Medial epicondyle.
Epicondyles. And then this.
Patella.
Okay, that's your guitar pick. Did someone say talus?
Oh,
Am I hearing things? What'd you guys say?
patella.
Patella, okay. Lateral view, A. Okay, what part of the patella?
The base.
The base. B.
Apex.
Apex. Let's talk, C.
Tuberosity.
Tuberosity. D.
The neck of the fibula.
Okay, so we have the neck,
The head.
the head, the apex.
Apex.
Okay, E, F, G.
Is that the popliteal surface? Or?
That's a little bit lower, so let's call that the, what does your book say? Does it say condyle or epicondyle? It says condyles? Okay, so condyles. Now, when we're looking at the lateral, here's another anatomical I can't think right now. Okay, I'm going to back up a little bit here. In the femur, okay, you got two condyles. You have a medial and you have a lateral. The medial condyle, just like in the ankle, where the fibula is going to be lower than the tibia, the condyles, the medial condyle is going to be lower than the lateral condyle. Okay, the medial condyle is going to be lower than the lateral condyle. So if we took an X-ray perpendicularly, you're going to see two separate condyles. But we're only seeing one here, right? We're only seeing one because one is superimposed over the other. Okay? So when we're doing a true lateral, we're also going to be using a tube angulation to superimpose those condyles. So we'll talk about that later. Okay, this is what it looks like here. So this is a lateral knee in which we use a perpendicular beam straight on. So the one that's going to be lower is going to be your medial. The one that's superior is going to be the lateral, right? K, medial. J, lateral. So in true AP, with a tube angulation, is going to superimpose the two condyles. So this is a very good lateral knee. This is not. Okay.
You say true AP or lateral?
What did I say? True AP?
Oh,
True lateral.
okay.
Sorry, true lateral. I is going to be the abductor tubercle, again, where there's going to be another ligament attachment there. So that's your adductor tubercle. This particular view on your left is a special projection that we used to isolate the patella. This is known as the sunrise view or the tangential projection. We will be practicing that in class. So A would be what structure?
Patella.
Your patella, and the space between that and your femur. B,
The
patellar
surface.
femoral joint or femoral patellar joint. D is going to be the patellar surface or the intercondylar sulcus.
So the patellar surface is part of the femur, right?
Patellar surface is part of the femur,
Okay.
yes. The patellar surface is part of the femur. And then you have your two condyles. E is medial, C is your lateral. Okay. So this is covering what we talked about earlier. So here we have an anterior view of the femur. In a true anatomical position, your femur isn't straight up and down. In fact, there's an angulation, a medial angulation of approximately 5 to 15 degrees, okay, from the perpendicular. So it is angled about 5 to 15 degrees. So what that means is because of this angulation, it's going to cause a tilt where the epicondyles are located. So this tilt is also going to cause a tilt down here at the knee joint. So it's also going to have a 5 to 15 degree angulation of that joint space. So to open up the joint space in a true lateral, what do we have to do?
Angle it.
Angle it which way? Which way are we going to angle it? Okay,
Column.
going to yeah, so because this is true perpendicular, true flat, and it's angled this way. So to open it up, we're going to angle 5 to 15 degrees towards the feet.
So is it the reason one of the condyle is lower than the other?
Right,
one?
exactly.
Because of the angulation problem?
Exactly.
Yeah.
Yep. Okay. All right. So the femur is going to be the longest and the strongest bone. The patella is 1.5 inches above the joint. So when we're taking knee x-rays, we're looking at the knee joint. The landmark that we're going to feel here is the patella. So we feel for the patella, and we're going to go about 1/2 inch below that, and that'll take you right in the center of that knee joint because of the patellar location. So when we're doing the knee, we're going to be feeling, the bony landmarks that you'll be feeling are the condyles and epicondyles, and then the patella. Okay, so 5 to 7 degree angle is shown at distal, medial, and lateral condyles, like so. So to open that joint space up, we're also going to apply a 5 to 7 degree cephalad angle for a medial lateral projection. For medial lateral, because we have 2 different types of projection. You have medial lateral and you have lateral medial. So it depends on which way the x-ray tube is going. So for medial lateral projection, it's going to be a 5 to 7 degree cephalad angle.
And then lateral medial would be cotted
The other
angle.
way, yes.
Be a cotted angle,
Yes,
right?
it'll be the other way. Yeah, because, okay, when we're doing, okay, I know it's confusing. We're going to be, when we're taking an x-ray of the knee, lateral, we do it, here I go again. We're going to do it like this, which is medial lateral, okay? Not like this, but like this, all right? Because we're approaching it this way,
It's not going the other direction.
medial to lateral, it has to be a cephalic angle. All right, let's discuss now the projections of the lower leg. So here we have an